Welcome to the final installment here on our pediatric things. Very tired, as if you cannot tell. Meningitis is going to be actually an infection of the meninges that kind of line the brain and the spinal cord within the skull. Um, yeah. Um, let's see. So some of our assessments we can do. Parents may say they had a recent ear infection. Or respiratory tract infection. A very common cause of meningitis is actually sinusitis, as it goes through they get an eye infection, it goes through the lacrimal duct, then it goes through the sinus, and then boom, goes right through the spinal cord, and then it reaches its way up to the kidneys. You will see a high fever as they're fighting off the infection and elevated white blood cell count, severe headache, ill for several days, poor feeding, lethargic, as of right here. So two assessments we can do that are actually pretty cool that unfortunately don't get talked about in our class, but as you can look up some doctor assessments here. Koenig sign is if you look at K for knee, you're going to take their knee and flex it, activate it essentially, and you will have like stiffness almost. And then our Koenig sign, you'll take the neck. Since they will have nuchal rigidity, you lift that up, they'll have the involuntary hip and knee flexion. So Koenig's very stiff knee, Brzezinski's nuchal rigidity with associated involuntary hip and knee flexion. Very two important measures to assess for it. Supportive care mostly. If the shock is present, give them fluids. Correct the problem. O2. Gastrointestinal emergencies. We have our nausea and vomiting. This is very commonly goes into dehydration and hypomulemic states. There are typically symptoms of other disease processes going on. Common causes: fever, ear infection, respiratory infections, stuff like that. Biggest risk: electrolyte imbalance and dehydration as you're vomiting all that fluid up. Mostly supportive care. Diarrhea. It's going to be anything more than 10 stools a day, depending on the age of the pediatric. Main concern, dehydration. So look at that. I would go right back up here and just do a fluid bolus, 20 ml per kilo every 10 minutes. I'm hoping you're catching on to the gist here, the 20 ml. Hypoglycemia. Give them sugar, give them fluids. Ingested poisons. Yeah, you should be good. Responsive poisoning patient. I think you should be good also on that. Very, very basic. Airway control, maintain inline stabilization in a neutral sniffing position. Remember, pad that void if you can, depending on the age. You do not want to pinch off that trachea. You want to keep that hidden as best as possible. Correct hypoxia, doing high flow O2, suction, draw thrust remover. If you definitely have any trauma, be susceptible to understanding draw thrust to give you your best instead of doing that sniffing position to prevent C-spine injury. Innovate one can't be maintained for an airway. Here's some of the things that we can do for stabilization for any of our C-colored patients. Fluid management. Well, if you can't get a IV, get IO. 20 mils per kilo. Reassess your vitals, no improvement, another 20 bolus. Pediatric analgesia and sedation. We can use morphine and fentanyl. They're your dosages. You can do phenyl IN. Not sure why though it's 2. For our adult dose, we got 1 mic per kilo. And just follow it up. I double check on this to see if this is the nasal. Kids are pretty susceptible to any head trauma, larger heads, weak neck muscles, very easy to hyperextension. Here's our GCSs, we already know this stuff. Cushing's triad is going to be our elevated BP. So if we have horrible, Subdural hematoma. Here's our brain, and we got a big old fat bleed right here. This can actually protrude down towards the foramen magnum, down through the spinal column, and actually herniate through. So things we're going to see is an elevated blood pressure, decreased heart rate, and abnormal respiration centers. So one thing you got to remember is, I'll kind of draw it out here. We have our purple brain, right? And we have our um, spinal column here. And we have our apneustic center. We have our stress receptors bearing reflex centers. So as we push down here, you also have your medulla oblongata and cerebellum. Cerebellum not so much right here, but you have your oblongata, which kind of controls any of your vital signs essentially. So that kind of just protrudes it down and really starts fucking with that process there. So you'll have just wonky ass vitals. Any ICP, just kind of look for a bulging fontanelle, asymmetrical pupils, and any of our posturing, like we see in our hemorrhagic strokes. Correct hypoxia, ventilate. O2 is going to be our vasoconstrictor here. So happy Tyler and happy neuro team. Consider an intubation of less than 8, or if the patient cannot control their own airway. Specific injuries. Yeah, I think we should be good on this stuff. You guys already know how to take care of patients. Attention pneumo, decreased breath sounds. Yeah, this is all stuff you guys already know. Injuries to abdomen. Just understand that our spleen and liver are very larger in pediatric, so they are susceptible to injury. So just kind of assess them. You can see if you have any hematoma or tenderness in that area, and then you can go throughout your treatment as follows. Fracture, splinted, you're good. Burns. I don't think this will be brought up in our test, but Parkland formula, depending on the body surface areas. Yeah. Okay, I'll be up there in a sec. We got our burns here, so just kind of go over this, take a pause, or just kind of look at this real quick. SIDS, baby dies in his sleep, unknown cause. Types of abuse, you guys know this. Special needs. Yeah, that should pretty much do it. If you need any further look into my notes here, they are posted on the Google Drive. If you're not on that, just shoot me an email and I'll share it on over to you. But yeah, thanks for tuning in on the pediatric, and any questions.